Well, good morning, everybody. We're going to go ahead and get started. I'm delighted to see some familiar faces here joining us. And for those who I haven't met yet, my name's Eric Wilkin. I'm the Creative Marketing Director at Lightfully Behavioral Health. Today, my co-host is Shelly Cambodge, who is our National Director of Outreach at Lightfully. We both want to welcome you to today's continuing education event called Precision in Practice, targeting what matters in mental health. So just a few things. First, if you happen to have any technical issues during today's call, please feel free to reach out to my co-host, Shelly. We'll pop her email into the chat right now. So if anything comes up, please just reach out to her. Also, before we dive into the main presentation, I want to share some quick updates about some services at Lightfully and some exciting updates. First, at our core, we are dedicated to changing lives compassionately. We specialize in primary mental health services, serving both adults aged 18 plus and adolescents ages 12 to 17. All of our programs are gender inclusive, and we welcome clients of all identities across our locations in LA, San Diego, Thousand Oaks, and San Jose. We pride ourselves on making quality mental health care accessible through extensive insurance coverage, high single case agreement rates, strategic location choices, and clinical excellence. I'm particularly excited to share some additions for 2025. First, our virtual PHP program with integrated psychiatric services. This expansion particularly allows us to reach more clients while maintaining high standard of psychiatric oversight that they need. Also, we now provide targeted treatment for schizoaffective disorder, which is exciting. Our comprehensive approach tackles the unique combination of mood symptoms and psychosis, empowering individuals to manage symptoms and move towards a more balanced and fulfilling life. Also, for those clients who might be hesitant to a higher level of care or might need a more flexible option, our short-term option is available, and this is the program that offers intensive support across all levels of care from residential to virtual, starting in convenient 2-week blocks. It seamlessly complements existing outpatient treatment during high-stress periods of life, and it provides comprehensive support through daily groups, individual therapy, family sessions, all led by licensed clinical experts. So if you think this sounds like it might be a good fit for a client of yours, our admissions team is ready to facilitate a smooth transition for your client. Okay, on to some logistics. For reference, today's presentation will be available online afterwards, and we'll address any questions that you might have during our Q&A session at the end. Go ahead and save them for the end of the presentation to pop them into the chat box. It is my pleasure to introduce our distinguished speaker, Dr. Nicole Siegfried, Lightfully's Chief Clinical Officer. Dr. Siegfried brings over 2 decades of mental health treatment experience and serves as an adjunct assistant professor of psychology at the University of Alabama at Birmingham. Her expertise spans eating disorders, mental health, and suicide prevention, with numerous publications and international speaking engagements to her credit. Dr. Siegfried's unwavering belief in recovery and dedication to helping individuals build lives worth living has shaped our approach at Lightfully. So, without further ado, Nicole, I will hand it over to you.
Thank you so much. Welcome, everyone. As you can probably tell right off the bat, I am a little hoarse. So I was sick on Sunday and Monday this week and lost my voice Tuesday, Wednesday, and Thursday. Just so you know, I have been doing everything to bring my voice back. I got an IV yesterday with a steroid in it so that I would be ready for today. I have my tea. I have my Hall's cough drops. So I think we're going to be good. I don't feel bad. I just sound bad. So I hope it's not too annoying for you. But just know that I don't feel bad at all. So I'm so glad that you're here today. And I'm really excited to talk about our model and how we apply this at Lightfully, and hopefully give you some tools to take back to your own practice. I started off in private practice. So I know what I always wanted as a clinician when I attended webinars. And so I want to make sure that I'm providing some tools that are really real life applicable so that you can use these with your own clients. So with that, I have, this is at the beginning and the end of the presentation. There's a QR code where if you want to take your phone, put it up on the screen and do like you're doing a menu at the restaurant during COVID, you can get all of the handouts that I will be discussing today, as well as the slide set. So you already have those that you can follow along with, or you can have those in your own toolbox. I tested it ahead of time to make sure that it was working. And then I tested it again when I got on just now. I think it's working. So if it doesn't for some reason, though, let us know in the chat and I can fix it at the end of the presentation if there's something going wrong. All right. So today I'm going to talk until 12:45 Pacific time, and then we'll have some time for questions at the end. So during this time, we are going to discuss the precision care model. First, how did we get here? Why are we at the place where we are today in terms of how to treat mental health disorders, and what are the gaps from the past that we need to address, and how are we doing that? What is the precision care model? I'm going to talk a little bit about process-based therapy. If you haven't heard of process-based therapy, it's time for you to hear about it. This is the newest wave of evidence-based interventions. And if I'm you, I'd be like, wah, wah, wah. This is different. The reason it is different is that it is saying, let's stop with the madness of evidence-based intervention protocols coming out year after year. And let's realize that we're more similar than different, and that the evidence-based protocols are more similar than different. What are the common ingredients across all of these protocols, and how do we integrate those in a strategic way? That's process-based therapy, and it's at the root of the precision care model. So I'll talk about that. We'll talk about what is a process. We like to call them drivers just because the term process can be confusing to our clients and sometimes even our therapists. Then we'll talk about the precision care model formula. Then how do you apply the precision care model formula or the precision care model to your own practice? I've got a case study that I'll be utilizing throughout that was a client. I've changed identifying information, but it was a client with us through our 3 levels of care. And we can use her as a template for how this might be applied. All right, so how do we get here? I could do an entire presentation on the failure of our mental health field. I'm sure all of us could. It could be a panel discussion. Let me start with the DSM. The DSM was created from a medical model lens, which was the best we had at the time. We thought that we could address psychiatric disorders or psychiatric symptoms in the same way that we do physical, and that by categorizing them, classifying them, and really understanding the symptom constellations and the diagnosis, that could drive treatment. Makes sense in physical disorders, right? So if you have a diagnosis of strep throat, or I could come in with a sore throat, let me say it that way, and the diagnosis of strep throat would be an important part of this because the treatment I would get is for strep throat versus tonsillitis versus throat cancer versus COVID would be very different. So in the physical world, the physical realm, diagnoses drive treatment. Way back in the day, we thought that that would be the same. I say we, most of us weren't alive then, but the leaders at the time thought that mental health would be the same way, but it's not. And any of you who are in the day to day with clients realize the limitations of diagnoses and the limitations of the DSM. So the DSM, actually, there's some debates around using a different taxonomy system for mental health that's in the works. These things take years and years, but based on this failure of the DSM. But for now, I think the DSM can be very helpful in understanding what what are mental health disorders or mental health constellations of symptoms, but not to drive treatment. So we do not use the DSM or diagnoses as part of our treatment planning, as part of the precision care model. Evidence-based research has also failed us. I can get on my soapbox about this. Originally, evidence-based research required a diagnosis. I always use Marsha Linehan as an example. She wanted to do research on suicidality, and she couldn't because suicidality isn't a diagnosis. So she chose a diagnosis with suicide attempts, frequent suicide attempts, as a symptom. It's borderline personality disorder. So that is where we're trying to fit square pegs in round holes. And even though that a lot of good research was done with DBT, and this is an excellent evidence-based intervention, the history of how we got to it really limited its applicability. And then the failure of evidence-based treatments in general. So 50% of people respond to cognitive behavior therapy, and as a leading evidence-based intervention. What I would say is that I'm a psychologist, so as part of my postdoc, I was trained in protocol delivered CBT. And so my sessions were recorded. I had this session one, this, session two, that. And I would get feedback on if I diverted from the protocol and how to come back on track. That is the way research is done. That is not the way that treatment is delivered in the real world. No one follows a session by session evidence-based protocol in treating a client. Most of our clients have more than one diagnosis, and we find that obstacles occur, and we try a little bit of this, a little bit of that. And therefore, when we talk about evidence-based treatments, technically, none of us is really delivering them in the evidence-based way. We may be integrating evidence-based interventions, but it is not being done, nor should it be done the way that it's done in research. So there's really a failure there and an over-reliance on this idea that if it has the stamp of approval of it being an evidence-based intervention or an evidence-based approach, that therefore it's going to have good outcomes. So what most of us have been doing as clinicians, we get trained in a bunch of different evidence-based approaches. And then we have our client in front of us and we do a little bit of this, a little bit of that. That's just the truth. And I think a lot of times because there's somehow there's shame in that, there wasn't a lot of instruction on how to do that well, because people would sort of say, you shouldn't be doing that. You should just be doing pure DBT. So, process based therapy, about 5 or 6 years ago, maybe a little bit longer at this point, Stephen Hayes and Stephen Hoffman came together. You may be familiar with Stephen Hayes. He is the founder of acceptance based therapy. So he's one of the gurus out there of evidence based interventions. Stephen Hoffman is a leader in CBT out of Massachusetts. And they actually, those of you who attend like APA conferences, if you're nerdy like I am, they used to have debates, sort of standing room only debates, where Hayes would be touting the benefits of his approach. Hoffman would be touting why CBT is better, back and forth and back and forth and back and forth. And finally, they came together to say, let's stop the madness. What we're doing is more similar than different. And we need to come together and we need to start a movement, if you will, of all of the leaders in these evidence-based approaches coming together to say, what we're doing is more alike than different, and how do we train people in those ingredients? And that's how process-based therapy was born. So process-based therapy, this is kind of a meaty definition I tried to highlight so you can home in on the important aspects, but it's a meta approach and a framework. So it's not a brand new updated evidence-based protocol. It's an approach of integrating different evidence-based approaches. It can be used with all types of psychotherapy, so that you don't have to be a cognitive behavior therapist, you don't have to be a psychoanalyst, you don't have to be a person-centered therapist. You could be all of those. And it identifies and targets what Hayes and Hoffman call active processes that can contribute to the client's problems, while also identifying processes of change that may promote healing in the client. It allows for therapists to develop a formulation, which, again, I can get on my soapbox about. We don't do enough of this. We don't do enough case conceptualization and formulation. And this approach really hangs its hat on this nail. A formulation, and then selected interventions accordingly, tailored to the client's needs. These are some of the seminal texts that are with process-based therapy that have come out in the past few years. If you're having trouble moving beyond the DSM, I'd start with that one. This learning process-based therapy, this skills training manual, it feels like, oh, that's what you'd want. It feels so meaty, but actually I would start with process-based CBT. Don't get caught up in the CBT there. They couldn't at first kind of realize their identity. And so they started off kind of trying to put this in a CBT package. But I'd start there, because this gives a little bit more of instruction around what the different ingredients are in these evidence-based approaches that are similar. And then I would go to the skills manual, because I kept saying when I first read it, it required a degree in physics to understand it. So what I'm sharing here today is a simplified approach that we use for all of our therapists, brand new therapists, and therapists that have been treating clients for a long time. And some of the skills in the process-based therapy skills training manual are a little bit more advanced. So what we call process-based therapy at Lightfully, we refer to it as our precision care model. We started off, I'll go into the history a little bit. We started off calling our model process-based therapy. It was a little confusing. Hayes and Hoffman did not check with me when they came up with the name of their approach. If they would have, I would have given them feedback that it was a little bit confusing, because what it reminds people of is process-oriented therapy. And it's not process-oriented therapy. We're not processing your childhood traumas, for instance. So people got confused. And so we thought it would be easier for us to talk about this in a way that described what it does. So we call it the precision care model. We also moved away from using the term processes because, again, that implies process as a verb versus as a noun. So we use the term drivers, which we've gleaned from David Job's work in the collaborative assessment and management of suicide risk. So the precision care model addresses drivers behind mental health symptoms, and it strategically integrates and applies evidence-based therapeutic interventions. Those are the two pillars. And that's what we'll be going through today, and what you all will be getting in your toolbox. All right, so when we are talking about drivers, it's important. I think you guys are going to really like this if you're in private practice, because whenever I was pulling all of this together as part of our model and looking at process-based therapy, I kept saying, oh my gosh, this is what we've always done. It's just not had a name. I love that we finally are putting words to what we've been doing sort of behind the scenes. And so I think you'll be excited about this, is that in the past, the focus has been on symptoms and reducing symptoms. And a lot of times this is the way that clients come in, is that they want a reduction in symptoms. And of course, symptom relief should be part of therapy. But sometimes we would stop there and it would be sort of this surface level intervention. So what we do in process-based therapy, or the precision care model, is that we go beneath the surface and we address these underlying drivers that may have contributed to the development of the symptoms in the first place, or at least contributing to the maintenance of the symptoms, keeping the client stuck. So we have higher levels of care here at Lightfully. So many of our clients this isn't their first rodeo. So they are coming to us because some of the things that they've tried in outpatient therapy haven't been working. They are stuck. We have to address what's going on underneath the surface here to get them unstuck. So these are some examples of negative drivers, for instance, that may have contributed to the development or maintenance of symptoms. Emotion dysregulation, emotional avoidance, low self-compassion, fusion with negative core beliefs, insecure attachment, nervous system disruption in terms of a fight, flight, freeze response. More and more. I could go on and on. Those are just some examples. It's important to differentiate between positive drivers and negative drivers, because we want to be able to interrupt negative drivers and promote the development of positive drivers as part of treatment. So I already talked about negative drivers and have some examples here. And when we look at positive drivers, we're looking at things like emotional flexibility, acceptance, value-centered living, mindful self-compassion, interpersonal connection as examples. And so sometimes those are the counterpart to a negative driver, but sometimes they're independent of a negative driver. One of the coolest studies that is part of process-based therapy is what Hayes and Hoffman referred to as the Death Star Project, because it went on for like 4 years, and they looked at all of the studies on what were the effective ingredients in treatment, what mediated treatment improvement, and brought all the stars together, so to speak. And so, as part of this, they were able to identify, this is a little word cloud that looks at the drivers of change that they were able to find in the study that were the main drivers of change. So you'll see some of these are positive drivers, some of these are negative drivers. So you'll see things like self-efficacy, acceptance, mindfulness, psychological flexibility as positive drivers. And that the promotion of those, the development of those is associated with healing and therapy in all of the studies they reviewed. You'll see other things like negative drivers, anxiety, sensitivity, rumination, and worry. What else? Dysfunctional thoughts. You'll see these as negative drivers. So reductions in those were associated with improvements in treatment. So based on this study, we at Lightfully bucketed our drivers into 4 buckets, just for the ease of creating some simplicity. So we have drivers associated with emotion, drivers associated with behaviors, drivers associated with thoughts, drivers associated with relationships. What I like to say is that if you show me someone who is suffering, and no matter what symptoms they have, what's going to be underneath are drivers in these buckets. So we should have our ear out in terms of listening for their drivers when they're telling us their history, when they're telling us their symptoms of what may be contributing to those symptoms or maintaining those symptoms. The goal in therapy then would be to help our clients pivot to positive drivers in the positive counterparts of those other negative buckets. So difficulties with emotions, negative drivers there would morph into, or we would develop positive drivers associated with emotion flexibility and acceptance. Difficulties with behaviors, drivers there would morph into positive drivers associated with value-centered living. For thoughts, the maladaptive thoughts or the negative drivers associated with thoughts would pivot into mindful self-compassion. And for relationships, the goal would be to move into positive drivers associated with interpersonal connection. So how do we do that? I'm getting my second glass of tea. Everyone would be glad to know. So far, so good. All right. We use what we call the precision care model formula. And Hayes and Hoffman refer to this as the guideposts of process-based therapy. There's 3 steps. These are the steps that you can apply in your own practice in working with clients. The first step is assessment. I'm going to talk about what that can look like. This doesn't have to be fancy schmancy validated assessments, although it can be. It can be old school clinical interviews. I'm going to tell you how to do it in both ways. The second step, which is really important, and we don't do this enough, is a personalized case conceptualization. So we need to take a minute with the client in front of us to say, these are their symptoms, but this is how this came to be. These are their drivers. Back in the day, we often would use diagnoses as a way to create case conceptualization because we knew some of the common precipitating factors and maintaining perpetuating factors. And so if we're not doing that, which we shouldn't be, in my opinion, we need to think of another way to do this that really is personalized to the client. Then we're going to select interventions according to that case conceptualization. So finally, instead of us being just out there fending for ourselves, saying, well, I've been trained in EMDR and I've been trained in IFS, I'm going to do a little bit of that, a little bit of this, I think that would be good for this client. We have a strategy now for what interventions might be the most effective for this client. Let's start with comprehensive assessment. So the way that we do this here at Lightfully is that we have validated assessments that we use and clinical interviews. We use symptom checklists. Don't get too caught up in these though, because these only give us a picture of what's on the surface. They're good indicators of improvement across time. It's it's our gold standard. I can get on my soapbox about that too, but it is a standardized measure of improvement. So, but if we stop there, all we're seeing is surface level improvement. So what we also want to look at is what's going on below the surface. So can we administer assessments that glean information here? So we deliver assessments that correspond to each of the buckets that I presented earlier. Difficulties with thoughts, behaviors, emotions, relationships. We keep these color coded just to help us. So it might help you follow along. We use green for thoughts, yellow for behaviors, blue for emotions, and sort of the salmon color for relationships. And so these are the assessments that we use. I'll talk a little bit about those. But you don't have to use those assessments. You don't have to use any of these assessments. You can also glean drivers from your biopsychosocial or your clinical interview. I've included in your handouts what we call our strategic history taking that includes questions that you'll want to ask to get at what some of these drivers may be for each client. So there's specific questions around the emotions bucket, the thoughts bucket, the behaviors bucket, the relationships bucket. And it will allow you to see, you don't have to ask all of those questions, obviously, just some of them, but it will allow you to see where are you getting the juiciest information from the client as to where they have the most where they're the most stuck, and the most where this most suffering is. You can also use other established clinical tools. One of my favorites and I might have it on here. Hold on a second. Yeah. One of my favorites is from CAMS, which is the Comprehensive Assessment and Management of Suicide Risk. I get no royalties, and I'm not associated with CAMS in any way. Um, but if you haven't taken this, if you're this training, I highly recommend it. It's like $500, and it will be well spent. With that, you get a skills session and consultation sessions. It's high value. And what I love about it is it's not the general how to work with suicide. Oh gosh, what suicide risks, and the hospital know they're okay to be here if we do means reduction. It's let's look at what's driving their suicidality and how do we treat suicidality. Love this. So this is an example from the suicidal drivers worksheet where you can start to look at themes that are coming out of their suicidality. So, and then you narrow it down to their two main areas. The other place that you're going to be getting themes is from collateral interviews with family or other providers if you've had a client referred to you. And then a tool that I also recommend is the process-based assessment tool. It's linked here. And I have this, I think, on another slide where there's a link to the website that is, this might be it. Yeah, this is the website. It's pbatsupport.com. It gives a lot of information on process-based therapy, how to use it in your practice, some examples, etc. But this is a weekly tool that you can use, and you can isolate questions that pertain to your client so that you can track drivers over time, I should say. So when you are performing a clinical interview or a biopsychosocial, things that you'll want to be listening for in each of these buckets are listed here. So the whole time that you're gathering history, you're going to be listening like, okay, is my client really hanging out mostly in this emotions bucket? Like that's where the majority of the problems are. They're saying things like, I can't handle my emotions. It's too much. My emotions are out of control. Or, I don't connect at all. I'm just numb. I'm a robot. Or are they talking more about behaviors? Or like, I can't get myself to do this, like motivational kinds of things. Or I can't stop doing these things. I can't get out of bed. I have no control. When you start hearing things around shame and self-hate, we see things in this thought bucket. I hate myself. I don't deserve X. I do deserve Y. I'm too much. It's my fault. And then difficulties with relationships. You'll hear some themes that come out here as well that might be feeling really isolated and misunderstood, or high conflict, or where they can't be authentic, or they're dependent on others. They're afraid others are going to leave them. So these are the things you'd be looking for. And like I said, in your handouts, you have the questionnaire that we use, and you can glean from that questions that you might want to use in your own clinical interviews. So I've listed here the assessments that we use. You're welcome to use the exact assessments we use. Great. Give us feedback on ones you think we should use that we don't. But we as part of understanding symptoms and drivers, in addition to the clinical interview that I just talked about, we are giving symptom assessments that give us the surface level symptoms, and these are in purple. It's some of the standard assessments that you're probably familiar with, like the PHQ and the GAD-7, the PTSD checklist, or we use the child trauma scale for teens, and then the core 10, which is, you may not be familiar with that. It's used more in the UK, but it is a measure of psychological distress. I like it because it has 10 questions and it gets at all symptoms in different categories, whereas the PHQ is just depression. The anxiety is just anxiety. The GAD-7 is just anxiety. So the core 10 spans a wide range of symptoms. And then following our color coding, these are the assessments that we use for each of our driver buckets. So for thoughts, we use the self-compassion scale and the schema inventory, which I'll talk to you a little bit more about. I'll talk a little bit about it here. If you're not familiar with schema therapy, this was originally developed by Beck and then Young, I guess in the 90s, and looks at some of those more ingrained negative core beliefs. And it can be very helpful with personality disorders, and people that are very fused with their negative core beliefs. I really find it helpful in that way. And so we use the schema inventory for that. For behaviors, we use the value questionnaire. So it's important for us to know how aligned clients feel with their values. Are there behaviors outside of their values? And what are their values? We use the AAQ, the Acceptance and Action Questionnaire, which is a measure of experiential avoidance and also a measure of psychological flexibility. So this is in the emotions bucket. And then we use the DERS, the Difficulties in Emotion Regulation Scale, for emotion regulation. And then for relationships, we use the Interpersonal Needs Questionnaire, which is a Thomas Joyner questionnaire that's used in suicidality research, but it's helpful at identifying what interpersonal needs are met and not met. And then in the gray down here, we are doing weekly check-in questions, and then we're also assessing the therapeutic alliance. So we're not giving all of these every week. It's just too much of a burden on the client. So I wouldn't expect that you all did this either. So we have and I'll show it to you, kind of a quick and dirty weekly assessment that we do that allows us to track client progress. So today we will be talking about Lucy. I've changed her name. This isn't her picture. But Lucy was a client with us who completed all 3 of our levels of care: residential, in-person PHP, in-person IOP. And she came to us after she had lost her job, and it was associated with her mental health. She wasn't able to go to work or really perform well because her PTSD symptoms were so severe. She had a sexual assault while she was in law school 4 years ago. It was there were multiple assailants, and she never told anyone, and went, I'm sorry, I'm trying to make sure I'm covering confidentiality. It happened at her horse barn, and with some of the workers there. And when she went home, she told her parents that she'd fallen off her horse because she was beaten up. And so never told anyone. And then as she started working with clients in her practice, she started realizing that there were things that were very activating in terms of her PTSD symptoms. People that she thought were getting away with things that shouldn't have gotten away with things, um, and she couldn't separate out her job from her trauma, as you could imagine. So she left her job, and then she moved in with her parents, and she came to residential treatment after that. So Lucy, we use a dashboard to help us make sense of the assessment. So this is her dashboard. I'm going to show you, though, you won't have this. I'm going to show you what this could look like for you, and how you could use this with your client. But just to orient you, this is at admission for Lucy, and her symptom checklist in the purple will start there. She had low suicide risk. She did have a suicide attempt in high school by overdose on Benadryl, but she was not currently suicidal. But her depression is moderate severe. Excuse me. Anxiety moderate, PTSD likely, and severe psychological distress. So this is the surface of the iceberg. If we look underneath in terms of drivers, we see that in terms of relationships, you can use the colors to help guide you. Blue is, think cool blue. She's in the blue zone for relationships. So this is important to note, because this might be something that we can use to help buoy her a little bit. But she's in the red zone for her emotions: high emotional avoidance, high emotion dysregulation. That makes sense when you're looking at something like PTSD. She's moderately aligned with her values, and she's identified courage, education, and humor as her top 3 values as part of this assessment. Her self-compassion is low in this thoughts bucket. And this is associated with the negative core beliefs of defectiveness and shame, fears of abandonment, and unrelenting standards from her schema inventory. So this gives us a picture of this client based on her assessments. And that can be used moving into our case conceptualization. So let's go to our case conceptualization. This is the second step. I would say the most important step. So I'm making a little choo-choo train here of our formula. So we've got first comprehensive assessment. And that was our first little car in the train. And I've got some of the assessments that we do here, but this can be through the clinical interview or other assessments that you give. And we're going to do a simple case conceptualization. So basically, we're just going to fill in the blanks of this sentence. Client symptoms of X are driven by Y. So let's look at this for Lucy. Client symptoms of distress, I'm pointing at the wrong thing. Distress, PTSD, and depression are driven by, look at our 2 buckets. These 2 buckets, we're looking at the reds. Low, so you could just do the bucket, difficulties with thoughts, difficulties with emotions. That doesn't give us enough oomph, though, really. What we know underneath is low self-compassion, fusion with these negative core beliefs. And then over in this emotions bucket, we know she has high emotion dysregulation and high avoidance. So we have a first step in understanding what is driving Lucy's symptoms and how this might start the process of identifying where we need to intervene. Hey, hold on a second. I don't know why that came back up again. Okay, so the next thing that we're going to go over is a case conceptualization tool that you have in your handouts. So you can use this tool as you're starting to get acquainted with process-based therapy or the precision care model. So we have our therapists use this as they are when they're working with clients, so that they can have sort of old school on a piece of paper or on a Word document what the case conceptualization is and what the intervention's goals are. So first, how did the client come to be? What we're looking for here is just precipitating factors, history, significant events, current life circumstances. So it can be just as simple as this: 33-year-old single Caucasian cisgender female diagnosed with I almost said multiple personality disorder, not this client, major depressive disorder, post-traumatic stress disorder, secondary to assault 4 years ago, recently lost her job and moved back in with her parents. That's sort of the precipitating, what she shows up with in treatment. And again, this is what we often see as what ends up guiding treatment, but not for us in the way we're going to do this. The second part of the tool that you have in your handout is around suicide risk. Now, her suicide risk was low, so this isn't going to be an area of focus for her. It could be that as we start working through some of her trauma, that suicidality peaks more for her. But at the beginning of treatment, it was low. She has strong support in her outpatient therapist, and she reaches out in times of crisis, and she's willing to use her parents in safety planning. She did have a suicide attempt in high school by overdose on Benadryl, but she currently denies suicidal ideation, intent plan. She's in our RTC residential level of care, where she has limited access to means. So this isn't going to be something that we'd focus on. If she were elevated risk, that'd be the first thing we focused on, regardless of any drivers. We'd get to the drivers through the work on suicidality, but that'd be the primary focus. Okay, then we want to fill in the blanks of what are the client's symptoms and drivers. So here, in terms of symptoms, what we know, I've put in this like symptom constellations, like because I don't want it to be like this is a diagnosis of depression, a diagnosis of PTSD, but she has symptoms of depression, which is depressed mood, hopelessness, amotivation. She has hypervigilance, numbing, avoidance of PTSD, and psychological distress. So that's in our purple area, the symptom area. And then we've got our color-coded buckets. And what we know here is that she has difficulties with emotion dysregulation, emotional avoidance, and in this thoughts bucket, low self-compassion and fusion with negative core beliefs. So if you were doing this based on a history taking, you would fill this in based on the client's answers to questions you've asked around their own processes or their own drivers. So if the client was bringing up a lot of self-hate, if that was the theme that you were landing on, you'd put this here. If it was more like around I'm not motivated, I can't make myself do anything, the only reason I'm here is because my parents made me come, maybe that goes in here. So you'll listen for those themes, and you will want to narrow it down though when it comes time for intervention selection as to where we start. So I'll talk about that in a moment. Okay, so we already went over this with this client. So we have this in here for her on her her case conceptualization. Her symptoms of distress, depression, and PTSD are driven by low self-compassion related to negative core beliefs of effectiveness, shame, fears of abandonment, unrelenting standards, and emotional avoidance. Actually, this might have been different clients that popped in here. Okay. So that brings us to our third step in the precision care model formula. So the step 3, the caboose of our formula train, is what we call data-driven clinical decision making. This is where we are going to be providing strategy in terms of what interventions we choose and why. So data-driven clinical decision making guides treatment planning and the selection of interventions. So on that worksheet that you have in your handouts, there's a section on treatment planning. So that's what we'll start with. I'm not going to go into, this is not a instruction on how to do treatment plans, but a way to apply process-based therapy or precision care model to treatment planning, what you'll want to be thinking of is that typically goals and objectives relate to symptoms. This is what the client's coming in with. They're going to say, I want to feel better. I want to feel less distress, or I want to decrease my thoughts of suicide, as an example. And then objectives will be the steps that you take toward those goals. Where we start thinking about drivers is more in the interventions section of the interventions that we are selecting. We're going to be selecting interventions that match those drivers to effect change toward goals. You may have clients that have been around the block and they're savvy enough to know, like, hey, I know my problems aren't just these symptoms. I know I have difficulties with emotional avoidance. That's what I need to work on. Great. If that's one of their goals, then you can have a goal that is also a driver. But typically clients will talk about symptoms as part of their goals. Okay. So based on wait, I think I have two slides, a repeat of 2 slides. Okay, so here, just coming back to our worksheet, we've got Lucy's symptoms and we've got Lucy's drivers. So based on her symptoms and drivers, what goals do we think would be likely? Well, what she came up with is I want to feel less distressed. I want to feel good about myself as a person. I want to function in life with a job, relationships, and living on my own. So this gives us a good place to start in terms of selecting interventions that are going to help her meet these goals. The interventions that we select are going to incorporate drivers. So how do we do that? We have here, I call this I call these orange bubbles of interventions, an outer orbit of interventions. Nicole Siegfried did not come up with these. Lightfully Behavioral Health did not come up with these. These are the interventions, the common ingredients across all evidence-based psychotherapies based on that Death Star project that Hayes and Hoffman did. This is what they came up with as every evidence-based protocol, every evidence-based approach has these slivers of these things in it, some more than others, but these ingredients are what are at the core of evidence-based approaches. So this is where it's the thing, we as therapists have been saying our whole lives of we really need a toolbox of interventions that we can apply based on the client's needs rather than just following, one stop shop, like we're just going to do CBT. And so process-based therapy provides that for us. So there's 13 of these here. We've assigned those to, or mixed and matched those to these intervention buckets. So difficulties with thoughts, interventions that you would see here are from those orange bubbles of the modification of negative core beliefs, mindfulness, self-compassion. The interventions that you'd see that we'd use to target with difficulties with behaviors would be around values, clarification, behavior management, exposure, motivational enhancement, difficulties with emotions, emotion reg, arousal reduction, somatic integration, acceptance, and difficulties with relationships would be interpersonal and family interventions. You notice we have crisis stabilization up here because this is by itself is what we would do first and foremost before any other interventions associated with drivers. So for Lucy, what interventions do we think we would do? So if we have her drivers as emotion dysregulation, we've got these buckets, difficulties with emotions, difficulties with thoughts. We're going to have interventions in those two areas. So this is what we'd be looking at. Now, here is a good rule of thumb. Whenever the emotions bucket is lights up, so to speak, we always start there. Why? Because the client is not going to be able to absorb any other interventions until their window of tolerance is wide enough that they can do that. So sometimes I'll have a therapist show me somebody's CAD report and say, it's red all over. What do I do? It looks scary on paper, but it's simple in terms of where we start. We start with emotions, unless suicidality is indicated, we'd start there. So that's where we're going to start. with Lucy. And then as we see improvement here, we'd move to this bucket if that's still where things were activated for her. And the way this is an example of the weekly outcomes measure that we do. So we do the core 10 each week, 10 easy peasy questions. And then we ask a proxy question for each bucket. So we have a question on emotions, we have a question on thoughts, we have a question on behaviors, and a question on relationships. And then we ask some other questions as well around appointment attendance, medications, ADLs, and hospitalizations if they're an outpatient. And then we track. So this is an example of if we were tracking for Lucy, this isn't hers, but hers would have looked like this, is we can see that her emotion regulation was low as she started, and the second week also low, but she's starting to see improvement. And so as we're getting into more and more of the work that we're doing in terms of interventions around emotion regulation, we're seeing improvement, which would be an indicator that we would now move to difficulties with thoughts. I thought it might be helpful for our last 30 minutes or so for me to take you through the interventions we did in action with Lucy. This is a good example of what process-based therapy looks like, because you'll see, I'm going to say hodgepodge, that sounds negative. You'll see, though, that it is a hodgepodge of different interventions, but there's a strategy for why we selected the ones we did when, based on the client's needs. You don't have to follow this template. You can follow your own based on the trainings that you have and the interventions you have in your tool belt. Okay, so what we started with Lucy was emotion regulation. We started with this bucket. When it's a driver, we start there. So we worked with her on some really good distress tolerance skills. We use a distress thermometer that we use. We have it out in our facilities so that our direct care staff, our client care techs, can help as well when clients are dysregulated. We have one for each client that's out, and then they have it on their bulletin boards. And then at lower levels of care, they work with this on their families so that families know how to best support at different levels of distress. So this is something we pull throughout treatment. We then have distress tolerance skills assigned based on the distress level. So at the top of the levels, we're going to use more quick and dirty kinds of skills, like stop, tip skills. And as we get down, the scale will be able to use more things that where requires a wider window of tolerance, things like pros and cons or radical acceptance. These are included in your handouts. And for Lucy, she was a little bit, you'll get this sometimes, she had done DBT with her outpatient therapist. So she felt like she could teach it. We get many clients that are in that same boat. So if you have someone who's sort of fatigued by DBT, a reminder with this is that we're not trying to just, use a hammer over and over when we need a different tool. We are trying to have you learn which skill to use when in which situation. So you may know all of these skills, but it may be that you haven't applied them at different levels of distress. So we that's one way that you can sell this for clients who've been like, oh, been there, done that, give me something else. So we integrate DBT with Lucy, we did with emotion regulation. A lot of the first work that we did with Lucy was from a polyvagal perspective and really looking at her window of tolerance, integrating Dan Siegel and Stephen Porges have done work on the window of tolerance, but really having her identify and map out her window of tolerance, which is very, this phase of treatment was very narrow. And she was launched into hyperarousal very easily. So what she did as a tactic, protective tactic, is kept herself in hypoarousal. I like this version of the window of tolerance because it has the faux window of tolerance on there. And Lucy is a good example because she would say, what I'm doing was like, you can't convince me that numbing isn't the right thing to do. And because this is so terrible. Oh, I keep pointing to my wrong one. This is so terrible. And so I would take numbing any day over hyperarousal. So she was in sort of this faux window of tolerance, and it appears like she's regulated until she's not. And the way that you would know is she would, when triggered or if she had a flashback, she would immediately catapult into hyperarousal. So there, you can use that sometimes when helping clients map their window of tolerance, of being able to see of how you never are really in an optimal zone. You just go straight from hypo to hyper, hypo, hyper. So this was really helpful for her. And she was able to identify ways which Porges and oh gosh, I can't think of Deb's last name right now. It just left me. I have to look. His counterpart, Deb, it'll come to me. But oh, somebody's telling me, thank you. I have to look now. Deb Dana. Yes, good job. Good job. Thank you. Deb Dana. She's wonderful. Get her books if you haven't. But what Deb Dana and Stephen Porges have identified as glimmers, where you can capitalize on little glimmers of ventral vagal activation, or what we call that optimal zone of arousal during the day, and start to identify those and increase those in frequency. She was able to do that, all while, I want to say this part too, all before we did anything around any kind of trauma work. I wish I could just take back what I said. This is trauma work. But what a lot of times clients think, and what sometimes newer therapists think, is that trauma work is that you have to start with exposure right away, or I've been there, done that, with myself, or that you have to start processing right away. And we need to really front load clients with skills to be able to do the rest of trauma work. So this is trauma work. And so we need to package it in that way. And I wish I would have said it that way when I'd started. The other piece of the pie here in terms of emotion work with her, and this was all at residential. She was in residential for about 30, I can't remember exactly, it was like 32 days, which is a typical length of stay. And a lot of the work that we did here was the work around emotion regulation, de-escalation, and avoidance. So all of you, I'm sure, familiar with the cycle of emotional avoidance, how it leads to short-term gain, but long-term pain. And so in the short term, it provides you relief, but over time, it intensifies whatever the feared stimulus is. So think about something that you're afraid of, spiders or something. So you avoid, and the act of avoidance is intensifying that fear. So our clients don't always buy into this. So we often jump into, we think exposure is sexy. I can do another talk on this. We all love exposures. And so we want to jump into exposures. I think that's a mistake. We first need to get buy-in to why avoidance is not working for them. It's what Hayes calls dropping the rope, getting out of the tug of war. And it might be that they need to try it 3 more times before they drop the rope. So this is one of the reasons I say people might come to treatment, multiple times, or if they're with you an outpatient, they may have to do this themselves until they're like, I'm ready to drop the rope. My strategies aren't working. Drop the rope in the tug of war. And so one of the things I like to say is that when we're talking about emotional avoidance and working on emotional avoidance, the opposite of emotional avoidance is not exposure. That's what we think. It's like if you're going to stop avoiding, you're going to need to start. Let's do an exposure hierarchy. Get you out there. No, it's acceptance. And so we need to do a lot of work around acceptance prior to some of the other exposure work, so to speak. So I think part of my soapbox series is how I want to go back and apologize to some clients where I feel like I forced exposure as the intervention, as an evidence-based intervention, when there were other more humane ways to get us there, or at least get us front-loaded before we did it. Okay, so we went through some of the things that we did with her in terms of emotions. Let's go to thoughts. So she stepped down to PHP. So it was in PHP IOP that she did a lot more of the work around her second 2 goals, which were the self-hate piece and the wanting to create a life worth living. So some of the interventions that the therapist used here were some compassion-focused interventions, leaning on Kristen Neff's work and compassion-focused therapy, and also IFS, which can be really helpful for people who have really strong inner critics or protectors, managers, as we say in IFS, which is Dick Schwartz. So this therapist had been trained in IFS, so she was able to pull in some of those skills. So some of the things that she did with the client were first around getting to know your inner critic And that's a way to sort of introduce IFS, because IFS sometimes sounds kind of weird. Internal family systems, for those of you who aren't familiar. And for this client, she really understood what it meant in terms of her inner critic. I'll talk about that in a second. And then the second piece of this was building her compassionate self, which could be looked at as part of a compassion focused intervention or IFS. And then a true self-compassion practice, sort of thinking of self-compassion practice like practicing yoga. It is a practice. It is not something that develops passively. It develops through practice. And so I love Kristen Neff's 3-step process for developing self-compassion, self-kindness, mindfulness, and common humanity. I think I have another slide on that. Probably preaching to the choir here, but sometimes newer therapists or maybe like just some hardcore CBTers, which I'm in recovery from, believe that the best way to work with your inner critic is to do thought stopping or thought challenging. And this is, again, my opinion, and the clients that I've worked with, this often seems to make the client dig their heels in more. We have to recognize the protective function of the inner critic. And when you get into a battle of trying to challenge the inner critic, you're going to lose. It's had, for Lucy, 33-year job of honing its craft. So we need to start with compassion for the inner critic. So that might be a novel concept for many of our clients. But we need to realize that the inner critic's been serving a function. And this manager for Lucy started way before her assault. She had this protector for her growing up as it relates to some of her negative core beliefs. She felt like her worth was tied to her performance and her achievements. And so that feels, as long as she was achieving, she feels like things are okay and she's worthy. And oftentimes that seemed to work pretty well until it didn't, until, her world was turned upside down by the assault. So understanding that protector is important, and helping the client learn through it. It could be through IFS or other methods of how to provide some compassion for why it's jumping in, because it's jumping in to protect and to create safety. When we talk about building the compassionate self, you can go about this in a couple of different ways. With Lucy, we did go around about this with, from an IFS perspective, thinking about the self as we talk about in IFS, utilizing those 8 C's of self, which are curiosity, clarity, compassion, confidence, courage, creativity, connection, and calm. One way you know you're operating in self is when you are demonstrating one of those traits. And so for Lucy, we started sort of dancing with her true self, core self, by leading with curiosity. That's often a way to get to self in a safe way. So we started with curiosity with her, and that allowed us, in some of the work with her inner critic, that allowed us to sort of practice some of those curiosity skills. And then compassion was another piece of that. And so, like I said before, compassion for the inner critic is a good place to start. The compassionate self does not talk back to the inner critic. The compassionate self is not a cheerleader, it's not a placater. One of the things that we'd used with Lucy that I like is the compassionate image exercise. She was she had a hard time imagining herself as nurturing. And so a way that her therapist helped her move into this was to think of someone else, maybe someone in her life or someone, a fictional character that is nurturing. And how can we use that image to lay the groundwork for a compassionate self? I have fairy godmother on here as an example, because sometimes people need someone fictional. Lucy chose her grandmother. Her grandmother was who she said is the only person who ever unconditionally loved her. Her grandmother had passed away. Actually, right around, I can't remember if it was before or after the sexual assault, but it was right around that time. So she had that happen at that time too. And so Lucy was able to to describe what her grandmother was like and bring that image to mind. And really, she had a bracelet that her grandmother had given her, and so she would um, uh, touch that bracelet to bring that compassionate image to mind. And she was able to start saying, "What would my grandmother say?" And that would be the groundwork that built some of her other skills. And then the actual self-compassion practice that I talked about before. I think this again is something that we forget. We think that self-compassion is something that is an outcome of the work that we do without realizing that there is intentional, it reminds me of gratitude is the same way. There's intentional practice that's required to cultivate self-compassion. It is a skill, not a trait. So mindfulness is part of this. Luckily, Lucy had worked on a lot of this during RTC. So the mindfulness piece of identifying how she was feeling, where she was in her window of tolerance, was something that she'd already been working on with her previous RTC therapist. She had a hard time with self-kindness. Her protector, her manager, popped in oftentimes when she'd say something kind to herself. And so the dialogue would go something like this, where she would say, "It's okay to be scared," and then she'd hear, another thought, her inner critic or protector say, "You need to you need to buck up. You need to do better. Stop being such a wimp." She used other words, but and so that usually would send her back on her heels. And so the dialogue shift ended up going like this, where then she would provide compassion for the critic of, "Thank you for popping in. I know you're trying to protect me right now, and I'm trying to protect me too. And so we're trying to do that together. And so I'm giving you a break, or I'm giving you permission to watch what I'm doing, but I am providing myself some compassion for the moment." So her dialogue practice went like that. And then connectedness, or what we call common humanity. This really started for Lucy when she was in RTC. Because she'd been silent about her assault, she had never talked to anyone else who had PTSD, or anyone else who had trauma. And so she really did believe that it was her fault and that she deserved it. There was something inherently defective about her. And it helped her to see that other people with PTSD had those same thoughts and that she didn't feel that about them. The other thing that we integrated from cognitive processing therapy, this is my favorite component of cognitive processing therapy for trauma, is an impact statement. If you had not been trained in a trauma-based modality, the cheapest and easiest one to get trained in is cognitive processing therapy. It costs $35. You get 12 CEUs through the Medical University of South Carolina. We have our clinicians take this training, so you can do it too. I get no royalties or kickbacks on that either. So cognitive processing therapy is very heavy on CBT. So it talks a lot about thought challenging, things like that. So you can take what works for you and what for your client, leave what doesn't. But I love the impact statement. So as Lucy was going to start doing some more of her work around, specifically around her trauma, her therapist had to write an impact statement, and this was hers. The overall feeling of what it means to have been assaulted is the feeling that I must be bad or a bad person for something like this to have occurred. I feel it will or could happen again at any time, which of course that's the reason her protector comes out, to keep her on guard. I feel only safe at home with my parents. The world scares me and I think it's unsafe. I feel all people are more powerful than I am and I'm scared by most people. I view myself as ugly and stupid. I can't let people get real close to me. I have a hard time communicating with people of authority. So plainly, I haven't been able to work. I don't trust others when they make promises. I find it hard to accept that these events have happened to me. So in your handouts, there's instructions for the impact statement as part of the cognitive processing therapy. But it's basically to write about how your trauma impacted you in specific ways in terms of how you feel about the world, other people, and yourself. As part of this, we also were integrating some work with her negative core beliefs. Some of this was going on more in groups than in her individual sessions, as the individual sessions were a little bit more focused on working on the impact statement with CPT, and then I'm going to talk about some of the EMDR things that were done with her. But in group, she worked on some of her maladaptive schemas. And actually, some of these have been worked throughout treatment, worked on throughout treatment, in addition to just group. So her maladaptive schemas, if you remember from her young schema inventory, are defectiveness, shame, fears of abandonment, unrelenting standards. I did want to, again, I do not get royalties on this, but the young schema inventory, you have to go through all of this rigmarole to use it, and you have to pay for each one and the results and all of that. This workbook is called the Interpersonal Problems Workbook by McKay, Fanning, Levin, Skeen, and it's a schema workbook. And so she got this workbook and did a lot of this work on her own, and then was using some of this in group as well. It has the inventory in there, so you can have your client take the inventory, and it allows them to identify their maladaptive schemas in the workbook. So she was using a schema flashcard, which is one of the things I like most about schema therapy. So the schema flashcard just allows you, and this is included in your handouts, allows you to defuse with your negative core belief. All of us have negative core beliefs. You all probably know the feeling of when one sweeps you away and you get hooked, as Russ Harris says. So the schema flashcard is a good sort of jostling technique to bring you back to reality. So this is an example for Lucy. So while she was in PHP IOP, she was really trying to communicate well with her parents. Her dad's trying to make conversation. He innocently asks, he says it's innocently asks, when I thought I might go back to work. And she immediately, her inner critic was activated, her negative core belief of defectiveness and shame, unrelenting standards activated. And so she's swept back into that. And if you've ever had that feeling, I have, you go back to almost a child state of like when that core belief developed. And it is so hard to attach to self during those times. So this can help. So she immediately felt disgusted, and we know how strong disgust is, one of the strongest human emotions. And she said, as part of this, you identify the schema. You say, oh gosh, when I'm feeling something that strong, based on this one question, and my reaction is that strong, something's being activated. Yep, it's my shame defectiveness schema, which is not right. There's nothing to do with that with this situation. That's based on my assault and then my childhood experiences of where I had to hustle for my worthiness. Reality testing, even though I think I should just give up, I'm damaged goods, the reality is, you fill in the blank. Sometimes it's simple of like, I'm not that child anymore. I can connect to my compassionate self. Whatever goes in the reality is fine. She was a little bit more logical. My dad's question has nothing to do with my worth. It's a reflection of his anxiety and his own communication difficulties. I can view myself through a compassionate lens, even with triggering outside stimuli. So she's an attorney. So this is something that can be helpful with clients, and it's included in this workbook. Other thing that we did with Lucy as in individual therapy was EMDR. As a psychologist, EMDR was kind of frowned upon compared to cognitive processing therapy or prolonged exposure back in the day. And so I didn't get trained in EMDR until later, until my recovery from being cognitive behavioral therapist. And because what people would say is, it doesn't matter, exposure is what's key. So it doesn't matter if you're doing this or whatever you're doing. But if you've been trained in EMDR, you know it's much more than bilateral stimulation. And what I love most about it is the float back technique and the work with negative core beliefs. My voice is going. The work with negative core beliefs. So in EMDR, this allows you to, and you have these handouts. If you're EMDR trained, you're already using these, but it allows the client to float back and associate earlier memories that gave her the same experience or feelings that she had with her presenting problem. So what she presented with was that it was her fear and hypervigilance and around her trauma. And as she dug into that, though, she was able to say that she really blamed herself. And so it was really self-hate. So she was able to then float back and find other examples of this, feel these feelings of self-disgust and self-hate throughout her life back to like age 7. And so it allowed her to realize that this assault was just the icing on the cake. And so the 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 reason, I mean, the assault in of itself would be enough to have these kinds of reactions, but the reason that it just really hit her at her core is she'd had other experiences that had contributed to the beliefs she developed after the assault. So as part of that, we assessed her negative cognitions. I'm a bad person. I deserved this. And then the positive cognitions of what she would like to believe. And she wanted to believe that it's not always the opposite. I've got examples in your handouts of some positive and negative cognitions that are common if you need to, sort of assist your client with this. But her positive cognitions were that hold on a second. I have to think of her positive cognition. Hold on, I've got to look for it. I'm worthy of love was her positive cognition. So it wasn't exactly the mirror image of the other side of the coin of her negative cognition. And so some of the work that she did in EMDR was working away from the negative, decreasing the negative cognitions and aligning more with positive cognitions through reprocessing and bilateral stimulation. And one of the things that she ended up doing that was particularly powerful for her was that she integrated her grandmother into her image as part of the trauma, that her grandmother was there for her after to comfort her and I guess we kind of got choked up, but to comfort her. And she was able to receive that love, and that helped her with her positive cognition of I am worthy of love. So that was something that really changed the connections in her brain in terms of what the trauma was related to, and reconnected it to her grandmother, which was part of the healing process. So throughout the work of EMDR, which for her was over the course of 4 weeks, 2 sessions a week, she was able to then revise her impact statement. So what you're asked to do then is just list the impact statement, or you're give the assignment again. Don't look at your old one, and write, now how do you feel about your trauma? And this is what Lucy wrote. What my trauma means to me is that I was raped, that an acquaintance and others I didn't know intimidated me and took that which was not freely given. Not only did they take sex, but they took my trust in myself, took feeling of control, and they shattered my self-esteem. I will always hate them for that. But one thing I won't allow them to take is my determination to get them back. She doesn't mean get the people back who did this, get back her self-esteem. I believed for a long time that the rape was my fault. I don't believe that anymore, and that is a great relief. I know I was frightened, and I did what I felt like I had to do to survive. I wouldn't freely do those things normally. There wasn't any willingness. It was all violently taken. Coming to that realization has brought about a lot of peace of mind and freedom. I'm now able to walk my parents' dogs in the evenings, whereas before I was afraid to be out after dark. I'll never be the person I was before, and a part of me is sad for that, but I now know that healing is possible. So as Lucy stepped down into IOP, lower levels of care, she started uh, getting back into life, creating the life worth living. We always say that at those lower levels of care, treatment should revolve around life, not the other way around. So she was able to move out into an apartment with a friend. She was going to still be taking a break from law work, felt like she couldn't be in that environment with and not without her trauma symptoms being too activated. So she was at that time working in like a coffee shop. But she felt really, and she got a pet, her own pet, but she felt really proud of herself for setting the boundary of going back to law, even though she felt like her parents wanted her to do that. She didn't feel like she was ready. So, in closing, I wanted to talk about some research studies that will be coming out in the next couple of months. We do have some initial support for the precision care model in practice at Lightfully. So these are the two studies that are currently under review. And basically what it shows, and our outcomes brochure is linked here as well. But basically what it shows, I'm going to give you a little image that might help. It shows that psychological distress at admission improves as a function of improvement in these drivers. That by addressing these drivers, that is what holds the effect of improvement in psychological distress, so that people are leaving in a mild distress level. And it's a function of improvement in their drivers. It's really exciting. So, in summary, previous approaches to mental health treatment have fallen short. Recently, an intentional integration of mental health interventions that target underlying processes of change has been proposed through PBT. Our model, the precision care model, integrates PBT. You kind of saw that in action today. And we have some initial research that's supporting the effectiveness of our model. All right, we've got about 10 minutes for questions. I have the flow code here, the QR code for you to get your handouts. And my email is here as well if you have follow-up questions for me. But Shelley, you might have been seeing if any questions were coming in that I could answer.
Yeah, just one so far about the CPT CE trainings, if you could include that information, which I can follow up with.
CPT is through the Medical University of South Carolina. So MUSC. So if you just Google, if you have trouble Googling it, then just email me and I'll give you the link. But if you Google CPT training, cognitive processing therapy training, Medical University of South Carolina, it will come up.
See if I can get the link for everybody right now.
Oh, great. Thank you.
Mm-hmm.
Any other questions?
I don't think at this time, Nicole, but thank you so much. And if any questions come up, like Nicole mentioned, her email address is right there, and I will put mine in the chat as well.
Excellent. We're going to be doing some other trainings this year, so keep an eye out. I purposely chose a client today that had more depression and trauma because the trainings we're going to do later in the year are going to be, I've done suicidality before, and then one we're doing later in the year is going to be on clients with psychosis. So if you have any of those clients in your practice, please come back and stay tuned.
And you will all be getting an email from us whenever we are ready to schedule these next set of trainings. And then there was a question about CEs. In your dashboard, you should be able to fill out an assessment right after this. And once you fill out the assessment, you'll have access to the CE credits.
You guys,
All
my
right.
voice made it. It might have
That
been
was
annoying,
incredible.
but it worked. We did it.
Well, thank you all.
Thank you
And
so
again,
much.
please reach out if anything comes up. But thank you so much, Nicole.
Thank you.